Hello, everyone, and welcome to our module on pericardial disease. The pericardium is the sac that surrounds the heart inside the chest, and it's made up of three layers. The outermost layer is called the fibrous pericardium. The inner two layers are collectively called the serous pericardium. The serous pericardium has two sublayers. One's called the parietal layer and one's called the visceral layer. The visceral layer is what surrounds the heart. Between these two layers, the parietal and visceral layers of the serous pericardium, is what's known as the pericardial cavity. And as we'll discuss later, this is the portion of the pericardium that fills with fluid in pericardial effusions and tamponade. The pericardium receives its sensory innervation from the phrenic nerve, and this is important because sometimes patients with pericardial injury, like pericarditis, can have referred pain to the shoulder, and that's because the phrenic nerve has common nerve roots with nerves that innervate the shoulder as well. There are three pericardial diseases you need to know for step one: pericarditis, tamponade, and constrictive pericarditis. We'll go through all these in the next few slides. Pericarditis is the most common pericardial disorder, and as the name implies, it involves inflammation of the pericardium. This is an autoimmune process. It's an immune-mediated attack on the pericardium. The triggers and the details are poorly understood, and in some cases after treatment, pericarditis recurs, and this is obviously called recurrent pericarditis. Pericarditis is usually benign, and the most important thing to do with pericarditis is distinguish it from coronary disease and other serious cardiovascular disorders. So you need to understand the symptoms of pericarditis. So the major symptom of pericarditis is chest pain, and it has very unique features that are different from ischemia. The chest pain of pericarditis is usually sharp. It's worse with a deep breath. This is called pleuritic pain. It's worse when patients lie flat, which is supine, and it's better when they sit up or lean forward. And all of these features are usually not seen in coronary disease. In addition, because this is an inflammatory condition, you may see fever or elevated white blood cell count or an increased erythrocyte sedimentation rate, all signs of systemic inflammation. Shown on the screen is an EKG demonstrating all the classic findings of pericarditis. When you first look at this ECG, you might think that there are ST elevations caused by ischemia. For example, this is the baseline ST segment in lead 2, and there's ST elevation seen here. You can also see some ST elevations here in lead V2. These ST segments are elevated. You can also see some ST segment elevations in other leads like F and 3. So basically what you see on the ECG are ST elevations in multiple different leads. Classically in pericarditis, you can see ST elevations in every single lead, and that's what differentiates it from ischemia. In ischemia, the ST elevations are localized to one area of the heart, like the anterior wall or the inferior wall. I've zoomed in on lead 2 here so I can show you the other classic finding of pericarditis, which is PR segment depression. The PR segment is the segment from the beginning of the P wave to the start of the QRS complex. And notice that this PR segment is going at a downward angle. That is PR depression, a classic finding in pericarditis. So the two classic findings are diffuse ST segment elevations in multiple leads and PR depression. Technically, there are 4 stages of EKG changes in pericarditis. Stage 1 is the first stage, and this is what I'm talking about in the last slide: diffuse ST elevations and PR depressions. About a week or so later, the ECG will look normal, and about a week or a few days after that, the ECG can develop T-wave inversions, and then it can go back to normal again. So what you need to understand is that sometimes you can see T-wave inversions in a person who had pericarditis a few weeks ago, and that's actually a normal progression of changes, not a sign of a new heart condition. The classic physical exam finding in pericarditis is called a pericardial friction rub. This is a scratchy sound. It's often described as sandpaper rubbing together, and it's heard throughout the cardiac cycle in systole and diastole. And I'll play an example of that for you now. There are a number of potential etiologies for pericarditis. Most cases are idiopathic with no clear cause determined. In this situation, we usually presume it's viral, but we don't have a definite diagnosis of the virus that caused the condition. Viral pericarditis is also common. The classic virus to cause this is Coxsackie virus. Often the pericarditis follows an upper respiratory tract infection, so the patient has a cough and a sore throat, and a week or two later develops pericarditis. That's a classic history of a patient with viral pericarditis, most likely from Coxsackie virus. Bacterial pericarditis can occur. This can be due to spread of pneumonia to the pericardium. It also may be seen after cardiac surgery if bacteria are introduced into the pericardium. And then finally, tuberculosis in some cases can spread to the pericardium. There are also cases that have been reported of fungal pericarditis as well. When patients develop uremia from renal failure, they often develop pericardial inflammation. This is called uremic pericarditis. There are 2 forms of post-myocardial infarction pericarditis. One's called fibrinous, which occurs days after an infarction. The other is called Dressler syndrome, which occurs weeks after infarction, and I talk about both of these in the video on cardiac ischemia. And then finally, patients with autoimmune diseases like rheumatoid arthritis or lupus often develop autoimmune pericarditis as a complication of their condition. The treatment is very straightforward. The mainstay of treatment is nonsteroidal anti-inflammatory drugs like ibuprofen. Steroids can be used in some cases. And then finally, colchicine is a special medicine that is used in pericarditis. It inhibits white blood cell action via a complex mechanism that's not well understood. Colchicine basically has three niche uses. One of them is pericarditis. It's also effective in gout, and it's also effective in the rare condition familial Mediterranean fever. And we usually add this to nonsteroidal anti-inflammatory drugs to treat pericarditis and lower the risk of recurrent pericarditis. Myopericarditis is the term we use to refer to myocarditis that occurs together with pericarditis. Sometimes the two conditions occur at the same time. Myocarditis is inflammation of the myocardium. It has a similar presentation to ischemia, including chest pain, ischemic EKG changes, and elevations of cardiac biomarkers. Some patients with pericarditis also have ischemic EKG changes and biomarker elevations, and we say that those patients have myopericarditis. Our next pericardial disorder is tamponade. In tamponade, there is an accumulation of fluid in the pericardial sac, and that fluid develops a very high pressure, so high that it restricts filling of the cardiac chambers. Now, you might think that it would require a massive amount of fluid to cause a high pressure and restrict filling, but it turns out that the amount of fluid found among patients with tamponade is variable. If the fluid accumulates rapidly, as occurs in trauma and bleeding, then just a small amount of fluid can lead to tamponade. The reason for this is because the pericardium needs time to stretch, and when the pericardial sac fills with fluid quickly, there's no time for stretching, and the pressure gets very high even with a small amount of fluid. On the other hand, if the accumulation is chronic and slow, as happens in cancer patients, then the pericardium has time to stretch, and therefore a large amount of fluid is required before the pressures get high and restrict filling of the cardiac chambers. This is an echocardiogram image of a patient with tamponade. This is the LV cavity right here. This is the wall of the left ventricle. This is the RV cavity here, and this black space surrounding the heart is fluid, and when that fluid takes on a high pressure, that can lead to tamponade. The water bottle sign is the classic chest x-ray finding of a pericardial fusion. The heart becomes enlarged and looks like a water bottle. This is a non-specific finding. You can see an enlarged heart like this in many conditions, but this is what's seen in a pericardial fusion in tamponade. There are many causes of tamponade. Cancer patients often develop this condition because of metastases to the pericardium. That leads to fluid accumulation. Patients who are uremic, I told you before, can develop pericarditis. They may also develop pericardial effusions, leading to tamponade. And in fact, any cause of pericarditis can potentially be complicated by an effusion and tamponade. And then finally, as I told you before, trauma can lead to bleeding in the pericardial space, which can rapidly build up a high pressure and cause tamponade. And the treatment of tamponade, no matter what the cause, is to drain the effusion to relieve the high pressure in the pericardial sac. Shown on this slide are the major clinical features of tamponade. Heart sounds are distant when you auscultate with the stethoscope. That's because the fluid collection around the heart obstructs the transmission of sound waves to your stethoscope. Dyspnea is the hallmark of tamponade. These patients are always short of breath. And finally, the jugular venous pressure is typically elevated. That's because the right ventricle cannot fill, and therefore the right atrial pressure goes up. And anytime the right atrial pressure is high, you will see elevated jugular venous pressure when you examine the neck veins. Beck's triad is a collection of three clinical findings that can be seen in tamponade. Those three findings are distant heart sounds, elevated jugular venous pressure, and hypotension. Beck's triad is usually only seen in trauma. You need to have a rapidly developing, usually traumatic effusion for this to occur. Remember that the pericardium does not have time to stretch in the setting of trauma, and therefore just a small amount of fluid raises the pressure in the pericardial sac significantly. This can lead to a severe impairment of LV function, so severe that the cardiac output drops and hypotension occurs. In slower developing effusions, like the kind that develop in cancer patients, the pericardium has time to stretch and dilate, and therefore you usually do not see Beck's triad. Instead, you only see dyspnea and signs like distant heart sounds and elevated JVP. Pulsus paradoxus is a change in blood pressure that occurs in tamponade. It is a classic finding of tamponade. In order to understand pulsus paradoxus, you need to understand that our systolic blood pressure always falls slightly when we take in a breath or inspire. In tamponade, there is an exaggerated fall greater than 10 millimeters of mercury, and this is called a pulsus paradoxus. It gets its name because if the tamponade is severe, the drop in blood pressure can be so great that you can no longer palpate the pulse. So hundreds of years ago, doctors noticed that patients with fluid around their heart would have their pulse disappear when they took in a deep breath, and they called that pulsus paradoxus. The physiology of pulsus paradoxus is shown on this slide. Anytime you inspire, you increase the venous return. This is the reason that right-sided heart murmurs like tricuspid regurgitation get louder during inspiration. This will increase the right ventricular size, but in the setting of tamponade, the right ventricle, if this is the right ventricle here, is surrounded by a high-pressure fluid accumulation. This means that the right ventricle cannot distend outward as it normally does. So instead, all the distension goes into the wall between the right ventricle and the left ventricle. That means the septum between the two ventricles bulges into the left ventricle. This shrinks the left ventricular size, and that drops the cardiac output. And that's why the blood pressure falls with inspiration. If it's severe, the cardiac output can get so low the pulse disappears. Usually it's not that severe, but if you examine the patient, you can measure the blood pressure change with inspiration, and you'll find a drop of more than 10 millimeters, and that is diagnostic of pulsus paradoxus. The normal drop is always less than 10 millimeters. It's high yield for your boards to know that a pulsus paradoxus can be seen in lung diseases like asthma and COPD. The physiology behind pulsus paradoxus in these conditions is very different from the physiology in tamponade. Normally, when you inspire, there is a slight decrease in left-sided flow. This is why murmurs on the left side of the heart, like mitral regurgitation, get quieter during inspiration. The reason for this change in left-sided flow is pulmonary pressure fluctuation that normally occurs when you take in a breath. These fluctuations in pulmonary pressure are exaggerated in lung disease. So, for example, in a normal patient, the pulmonary pressures only change from about 0 to -5 millimeters when you take in a breath. In patients with lung diseases, the change can be up to 40 millimeters, and for this reason, there can be a large drop in left-sided flow, and this leads to pulsus paradoxus, the same finding you see in tamponade, but via a totally different mechanism. Shown on this slide is the measurement technique to obtain a pulsus paradoxus from a patient at the bedside. This probably won't come up on the step 1 exam, but med students are often asked to do this on clinical rotations, and it can be embarrassing if you know how to interpret a pulsus paradoxus but not how to measure one at the bedside. You begin by putting the blood pressure cuff on the patient the way you normally would to measure the blood pressure and placing your stethoscope in the antecubital fossa in the normal fashion. You then raise the cuff pressure until you hear no Korsakoff sounds. Importantly, the patient should be breathing normally. Do not ask the patient to take in a deep breath or do anything unusual. Their respiratory pattern should be completely normal. You then slowly lower the cuff pressure. So let's imagine, for example, you pump the blood pressure cuff up to 150 millimeters and you hear no Korsakoff sounds. You then slowly let the pressure come down, and let's say you get to 130 millimeters and you begin to hear intermittent heart sounds. You will hear a bump, bump, and then no sounds, and then a bump, bump. What's happening here is that you are hearing sounds only during certain parts of the respiratory cycle. You then continue to lower the blood pressure cuff, and let's say you get down to 125, and you will hear Korsakoff sounds throughout the respiratory cycle. So bump, 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 bump. The difference between these 2 points, 125 and 130, is the pulsus paradoxus. That's how you do it at the bedside with the patient breathing normally and identifying the point where you hear intermittent sounds and where you hear constant sounds. There are some EKG findings that may be seen